Very good. All righty then.
Good afternoon. I'm Martha Beatty, a League of Women Voters member. Welcome to LWV Presents Insights and Perspectives. Today we'll be talking to Bob Brownstein, who's chair of the Santa Clara County Healthcare Reform Implementation Stakeholder Working Group. Bob is currently the Director of Policy and Research at Working Partnerships USA, which the county tasked with creating the framework for the Stakeholder Working Group. Our topic today is local implementation of the Patient Protection and Affordable Care Act, more commonly known as ACA or Obamacare. Bob, could you give us an overview of the objectives of that act and how it's going to attempt to change the healthcare delivery in the United States?
Sure. It's a large and complicated program, but let me at least begin by talking about the job that the bill intends to do, what the purpose of it, and the basic method that it's using to try and accomplish that purpose. So the reason that the Affordable Care Act was passed was the recognition that there were several problems with the American healthcare delivery system. The first major problem, a large number of people lacked health insurance. Second major problem, very significant increases in the cost of insurance for the people who did have coverage. And third, when you compare the health of people in the United States versus the health of people in other Western developed countries, our rankings didn't look that good. So we have a lot of people without insurance, we're spending a lot of money and we're not getting good outcomes. That suggested that something should be done to try and improve the system. Now, the explicit goals of the Affordable Care Act are to expand coverage, to maintain or improve the quality of care that people get and the quality of their health, and also reduce costs. And when we talk about this measure, we'll see that it's not that easy to do all three of those at once, particularly expanding coverage and improving quality and at the same time reducing costs. In terms of the structure of the Affordable Care Act, although it's complicated, it actually is relying on major elements of the existing healthcare delivery system. Most people in the United States that have coverage have it through an employer-sponsored plan. That will still be true after the Affordable Care Act is fully implemented. There will continue to be government insurance programs, but they're the same ones we have now: Medicare, Medicaid, and S-CHIP, the program for children. And for the people who will get expanded private insurance, that is through the healthcare exchange, the new marketplace, which in California we call Covered California, that's all going to be managed by private insurance companies. Many of those are the companies that are insuring us now through our jobs. They're very familiar firms, and Blue Cross, Kaiser. So a lot of this structure is going to be very similar to what we have now, but there will be some things that are definitely new and different. One is a lot more people are going to have coverage through Medicaid. That is the insurance program that the government runs for low-income people. Secondly, there will be a mandate so that people who don't have private insurance will have to get it or pay an IRS penalty. And third, the basic way that we finance healthcare is going to be changed over time, both through the Affordable Care Act and also the way the government is going to be managing Medicaid and Medicare. And this is a very significant change in the way that we've previously been doing business, away from fee-for-service and more towards outcome-based care, population-based care.
You were talking about that. That just sounds so fascinating. That is going to be a big change, and I can see how that's going to be something to figure out how to implement. That is going to be really difficult. Can you, before we get into more on that, could you provide any statistics on how many are uninsured in our county and how many could pick up coverage through the efforts of ACA?
Sure. Now, the numbers are not precise because we're making rough estimates, but we're assuming that roughly about an additional 50,000 people will be eligible for Medi-Cal in Santa Clara County under the Affordable Care Act. It looks like about 90,000 to 120,000 will be eligible for the exchange. And then there'll still be roughly 100 to 150,000 who won't have insurance, either because they don't qualify for it, or in some cases there will be people who choose not to get insured despite the fact that they have to pay a penalty. Okay,
all right. I know that I used to be a contract worker, and I know that those people are really waiting for insurance to come in. That's going to be great for them.
There's a lot of people who will rush to sign up, but there's others that are going to need to be convinced, and there's probably some who will refuse to be convinced.
You talk about Medicaid, and it's going to be expanded. What's the expansion? I know a lot of people are interested in that.
Medicaid is going to go up to 138% of federal poverty level. That is, the income level is going to go up, and people who are below that level, assuming that they're legal citizens of the United States, will be eligible for Medi-Cal.
And then there are also subsidies, aren't there, for others that are up to a higher level?
Okay, so, well, once we move beyond Medi-Cal, then we're talking about people who are going to have private insurance under the exchange.
Yeah.
And when you're someone who is potentially eligible for the exchange, that covers everybody who has an income above the Medi-Cal limit, up to 400% of federal poverty level. And within that spectrum, depending on what your income is and your family's size is, you will get tax credits to offset some of the costs of health insurance.
Does that mean you're going to have to fill out a long form?
Well, no, actually it's going to be fairly user-friendly.
Okay,
the idea is that when you actually apply for health insurance, at that time, you'll be indicating what your income is, where you fit in this family size, federal poverty levels matrix. And at that time, the cost of your health insurance that's going to be offset by the federal government will be immediately applied to your health insurance costs. So you're not going to have to pay the insurance company and then fill out forms and try and get Washington to reimburse you. You'll get the tax credit at the front end, which is much better for most people, especially people who are lower income and are going to be depending on a big tax credit in order to be able to write that check for health insurance at all.
Right. And can you say something about the essential health benefits basics?
Yeah. One of the things that the Affordable Care Act really wants to make sure is that health insurance is done in a way so that people get a very solid core of health services. They don't want to have a repeat of what happened when they first started to have health management organizations 20 years ago, when all sorts of fly-by-night outfits got into the health insurance business and got people to sign up for insurance that really didn't cover anything at all. And people paid premiums and then never really got health care. So there's a broad spectrum of services that are essential. That is, every firm that's going to be providing coverage without exception in the health exchange, Covered California, is going to provide these services, and they include, it's a little bit lengthy list, ambulatory services, that's outpatient services, emergency services, hospitalization, maternity and newborn care, mental health and substance abuse services, other behavioral health treatments, prescription drugs, rehabilitative services, lab services, preventive wellness management, chronic disease management, pediatric services, and under pediatric services also dental and vision care.
So dental and vision just for children?
Just for children.
Yeah. Okay.
But you can be assured, you can't just say, oh, here's the exchange, I want to sell insurance under it. You have to be certified by the exchange to be a
Okay.
qualified health plan. You have to be a reputable outfit. You have to demonstrate your ability to actually provide the services that you're getting premiums for, and you have to show that you're going to be able to provide all these services.
Okay. And I know there are different levels. They call them platinum, gold, silver, bronze. I
Right.
don't know if you want to get into that at all.
Well,
but-
okay. They call it the metals plans, okay? And bronze is the least expensive and the lowest benefit plan, then silver, then gold, and then platinum. The difference between these plans is how much of what they call the actuarial valuation of the health services gets paid for by the health insurance company and how much gets paid for by you. Now, by actuarial valuation, what they really mean is the total costs of the health care. So
Okay.
an estimate is done that says, okay, considering this set of benefits, this is what it's going to cost to provide health care for this population. Excuse me. So of that total cost, how much is paid by the insurance company and how much is paid by the client, the person who's paying the premiums? So if you're looking at the platinum plan, the best plan, the insurance company will pay 90% of the actuarial valuation. You're going to be paying the dramatic lion's share of the cost of your health care. But if you go down to the bronze plan is going to have more deductibles, more copays. It's going to be 60% of the total actuarial valuation. Now, of course, you'll pay less
Right.
for the bronze plan. Now, it's important to recognize that there actually is one more plan that's available in addition to the 4 metals, and that's what's known as the catastrophic plan, which is only available to people who are under 30. The term that is often used for these people is the invincibles. That is, they're healthy, they're young, and they think they'll never need to see a doctor. Little do they realize that the world doesn't play that way. But the catastrophic plan is essentially a very high deductible plan, and it uses the deductible levels that are developed by the IRS for IRS-defined high deductible plans. So for an individual for 2013, that deductibility is $6,250 for an individual and $12,500 for a family. Those are very high deductibles. Now, people are going to be able to get these catastrophic plans, probably, you're a young person to begin with, you're relatively healthy, you're going to be able to get these catastrophic plans cheaply.
Yeah.
But people should just think, because I don't know a lot of people who are 27 who have $12,500 in cash lying around. And the deductible is on you. The
Right.
company is not paying anything until that deductible is taken care of. So
But they're
the
invincible.
Yeah, they're invincible. Well, the catastrophic plan may be deceptive in that it looks like it's the smart thing to do, but it may not be.
Right. Well, we're going to have a break in this conversation. We're going to take a break for a fun fact, and we'll be back in 30 seconds. So we're not done on this.
We'll go as far as we can. Well, we should probably do a little bit,
Welcome back. We want to continue with what's been happening, what we've been discussing, and Bob, can you take it from here?
Sure.
Okay.
So there's a few other sort of basics that people should be aware of in terms of the Affordable Care Act and how the exchange is going to operate. First, in terms of individuals, I mentioned that there is a mandate, and after January 2014, virtually everyone is going to be required to have health insurance. But not everyone. There are some exemptions from the mandate, and those would include people who would have to pay more than 8% of their income for health insurance, people whose incomes are very low, people who qualify for religious exemptions, undocumented people. Now, in many cases, they might want to be covered, but they can't be under this measure. People who are incarcerated, obviously they get their care through the state through another system, and members of Native American tribes. So those groups
Okay, but
aren't.
they have their own
They
health,
have their.
yeah.
Yep. So those people
Okay.
aren't covered by the mandate. Now, the mandate has sanctions associated with it. And the sanctions will be going up each year, 2014, 2015, 2016. In 2014, it's 1% of your income. 2015, 2% of your income. 2016, 2.5%. And these are sanctions that would be applied when you pay your taxes. So the program is designed to really put inducements or pressure on people to take advantage of the exchange and try and get health insurance. And there's two reasons why it's being set up this way. One is, if you don't have insurance, in most parts of the United States, you will not be left there to die if you get sick. The fact is, you will get access to certain levels of care, and everybody else is paying for it. So everybody else has a right to say, hey, we don't want to leave you to die in the parking lot. We want you to have health care, but you can't just say, I don't care, it's not my problem, until I get sick, and then everybody should pay for me.
Right, the safety net idea.
Yeah, to say it's you know it's one thing when people don't have the opportunity to have insurance. They'd like to have it, but they can't get it, which is the way many people face it now because of pre-existing exclusions. But once we have a system so that everybody can get coverage, the idea is you shouldn't be able to say, no, I'll just wait until I get sick, show up in the emergency room, and then make everybody pay for me.
Right.
There's an equity issue there. The other reason that the mandate has to be treated seriously is because the Affordable Care Act requires the insurance company to provide insurance for everyone, no matter how sick you are. Well, the only way they can do that and not go broke is to cover a large volume of people who are also healthy. So you have to build up that volume of healthy people in order to be able to be sure that everybody who is sick, and no matter how sick they are, will be able to get coverage. And the Affordable Care Act says there's no lifetime benefit limit on your benefits. So if you get really sick, you will continue to get your health care as long as it takes. If you have a chronic disease and you live for another 30 years with it, you're covered for 30 years. For the insurance companies to be able to pay for that, the healthy people have to be in the plan.
Now, Bob, what's happening locally? I think we better get to that before the end
Okay.
of the program.
So all of these systems were put together through debates in Congress, but the fact is people don't get their health care in Congress. They get their health care locally. So the health care delivery systems in this county and everywhere else in the United States are having to adjust to make sure that they can function well under the Affordable Care Act. So there's a variety of things that will need to be done in order for that to happen. The first thing is people in the county have to learn about the Affordable Care Act. As I mentioned, there's all these different metals. There's going to be dozens of different plans that are going to be offered for your choice once the health exchange is open. And for a lot of people, it's going to require information and help to figure out what's the intelligent thing to do. So the Health Exchange Covered California locally is going to be spending significant amounts of money on outreach and information to get people ready so they'll know how the exchange works before the enrollment period officially opens.
Which is in October.
In October. And in addition to that, there will be people who have jobs which are referred to as assisters or navigators, and their mission is to work with people to make sure that people understand how the system works and what their options are, how much they'll have to pay, how much they can expect in tax credits, et cetera. And there's a good website that Covered California has put together that these assisters can direct people to, and that's coveredcalifornia.com, which also is a way of helping people understand what their options are. Now, one thing these assisters will not do is they will not be fronting for a specific insurance company. They'll let you know what your choices are. They'll let you know what the costs and benefits are, what your premium support would be, your tax credits, et cetera. But when it comes time for you to choose between Kaiser or Blue Cross or somebody else, that's your choice. And these assisters will not be nudging you towards
And
one.
they'll be trained and
Yeah,
certified.
and and this is not sort of something that's self-appointed. You have to be trained and certified by California, by Covered California, in order to do these roles. The other thing that we're trying to deal with locally is we're trying to make sure that the healthcare delivery system is ready to meet people's needs as they get into the exchange and as they start participating in the new world of healthcare that's going to be much more focused not on fee-for-service, but on population-based care and on health outcomes. And that means locally we have to make sure that we have the capacity to provide adequate care. You know, it doesn't do you any good to have a health insurance card and you call up the clinic and they say, we'll see you in 4 months, right?
Yeah.
Have to be enough clinics, have to be enough primary care physicians, have to be enough specialists to be able to provide the care for the additional people who have coverage. There's also going to be changes in the way that healthcare is going to be delivered, much more of a focus on trying to keep people healthy, as opposed to fixing them after they've become unhealthy or sick. So there's going to be an effort to try and get people into what is known as a medical home, which is either a primary care physician or a primary care team that is going to be looking at an individual and trying to figure out what are the things that we can do to stop this person from getting sick so we don't have to do an acute intervention. You know, what's their nutrition? What's their level of exercise? Are they getting the preventive exams they need and the screening exams to make sure that if they have some developing illness, it can be dealt with at a very early stage, which is better for someone's long-term life and well-being, and also is a lot less expensive than letting it get to a point where it becomes much more serious.
So you are part of a working group, or you're actually a chair of this working group. And what are they? Can you tell me a little bit about the group and what they're
They
doing?
meet regularly, and they're dealing with all of these kinds of issues, like how can we try and develop better prevention programs so that the high level of obesity amongst young people, we can get that under control? Because the fact is, one of the big goals of the Affordable Care Act is reducing the cost of health care. We will never reduce the cost of health care if very large numbers of people wind up with diabetes because nobody tried to get them to control their weight when they were younger. It's going to be impossible to control the costs if people get that sick in very, very large numbers. We have to start thinking about changes in the healthcare workforce. If the idea behind the Affordable Care Act works as we expect it will, fewer people will be getting care in hospitals, and people will be getting much more outpatient care. They'll be getting more wellness care. We'll need more people, not just assisters who will be helping people navigate covered California, but assisters who will be helping people stay healthy. That is, people who will be working to assist those who have chronic diseases to manage their illness, control their weight, check their insulin, whatever it is, take their medications so that they can be healthy and not have to be showing up at the hospital for an acute episode. These are new skills, new classifications. Who are the workers that are going to be providing those services? We have to figure out what the certifications will be, what the training should be, and start developing those programs so that the people will be ready to provide those services when we as potential patients need them.
Now, that's not going to be next January.
No.
Okay.
This is a long-term effort.
Right.
I mean,
because that's
there's
an awfully big change.
Yeah, the reimbursement system is going to change.
Yeah.
And, right now, if you go to the hospital and get an infection at the hospital and have to go back, the hospital didn't do it on purpose, but they will make money because you came back and it's a fee-for-service system. Under the new system, they will lose money. So people are going to have to adjust how they understand the finances of their institutions and work to avoid those kinds of things. And the whole distinction between medical services and social services is going to be blurred. And people will realize, and health providers will realize how important some social services are to keep people healthy. One thing Medicare discovered was a really outrageous percentages of people on Medicare were going to the hospital for an acute ailment and then going back again in 30 days with some kind of related problem. And Medicare said, we have to figure out what's going on. It's terrible for patients. It's costing a fortune. They studied the situation, and they discovered who are the people who are going back to the hospital? Just the people you'd expect, people with no support network.
Right.
People who left the hospital had nobody to help them understand the directions that the physician gave them, nobody to make sure they got their prescription filled, nobody to make sure they took their meds. Result, they're back in the hospital in 3 weeks. So, how do you fix that? You have somebody call them up
Right.
and say, could
Right.
you understand the directions? No, let's go over them. Did you fill your prescription? No, we're delivering the medicine. Did you take your pills this morning? No, take it right now. It's relatively inexpensive, but those kinds of changes in the way we do healthcare will have very good benefits both for patients and for the bottom line.
Now, I noticed that we do have some local outreaches coming. There was a very nice article in the paper about the different languages. I've forgotten but on the front page, as I recall. And what's happening there?
There's a whole big collaboration of groups in Santa Clara County that have sent an application into Covered California for a large grant to do outreach. And assuming that grant is covered, there's going to be people coming to all kinds of meetings, your neighborhood meeting. You know, there'll be legitimators, that is, people who are credible in certain communities will be putting meetings together to inform people about how the health exchange is going to work. If you go to a nonprofit for some service that's not health related but something else, you'll find information and people ready to tell you that the health exchange is coming and giving you information about how to get ready. So your churches and synagogues and mosques, they'll all have people who have information about how if they want to participate in the outreach, about how the program is going to work. So there's going to be the emphasis to have just about every kind of institution that people normally interact with, where they work, with your labor union, where you work, where you play, where you pray, where you socialize. All those places will have information about how this is going to work, so people will be able to get up to speed and will be better able to make the right choices for them when the open enrollment period happens.
Well, you know what? We're going to have to end our conversation now. It's been great. I thank you so much for joining us.
My pleasure.
And thank you for being with us today. And if you want more information about our league, please go to our website, lwvsjsc.org. And of course, we have smartvoter.com for when we're in election periods. And you'll find information about our league and programs, and also a membership form and contact information. And thank you so much for joining us.